TROPiCS-02 evaluated the novel TROP2 antibody-drug conjugate, Sacituzumab govitecan, compared to chemotherapy of physician choice in patients who had heavily pretreated hormone receptor-positive HER2-negative breast cancer. And just to brief review of the patients and the eligibility, patients had to have received a CDK4/6 inhibitor and taxane in any setting, 1 line of endocrine therapy for metastatic disease, and at least 2 but not more than 4 lines of chemotherapy for metastatic disease. And the median number of lines of chemotherapy was 3. The median time from diagnosis of metastatic disease until randomization was 4 years. 95% of patients had visceral metastases, and about 40% of patients had received CDK4/6 inhibitors for more than a year. So this was a very heavily pretreated and uniformly pretreated patient population. We showed at ASCO 2022 and published recently in the Journal of Clinical Oncology that progression-free survival was significantly increased with sacituzumab compared to chemotherapy of physician choice. About 48% of patients received eribulin as their chemotherapy, and then it was divided up between the other 3 agents, vinorelbine, gemcitabine, and capecitabine, the smallest number receiving cape. Most of the patients had received prior capecitabine, and you couldn't receive the same drug again. So the progression-free survival was designed by blinded independent central review, was powered for a hazard ratio of 0.7. We reached a hazard ratio of 0.66, which was highly statistically significant. But the median difference was about 1.5 months, which had some people concerned because it was so small. But actually what we saw was in the first 2 months, there was a big drop-off, and that was similar between the 2 arms. So, you get these patients who are really late in chemotherapy treatment for metastatic disease, hormone receptor-positive disease, and they just have resistance to everything. And so what we did, in that situation, Kaplan-Meier is not quite as useful, and the medians aren't representative. So we did landmark analyses, and at 6, 9, and 12 months, there were more patients alive and free from progression who received sacituzumab compared to those who received chemotherapy of physician choice. Notably, at 1 year, 3 times as many patients were alive and free from progression with sacituzumab. And at that first analysis, we saw no new safety signals. The most common toxicity is neutropenia, although there wasn't an increase in febrile neutropenia compared to TPC, treatment of physician choice. And then diarrhea is the next most common toxicity. My experience, and I think those of investigators who've used the agent frequently, is that we can manage this toxicity very easily in a straightforward way, if you're aware of it up front, by giving growth factors in the right setting, anti-diarrheal agents, and dose reducing and dose holding when appropriate. Dose reducing working very well for people who have sensitivity to the irinotecan metabolite SN38 and develop diarrhea. Again, still not as common as we had thought in the beginning in terms of toxicity. And the earlier we treat patients, we've seen with triple-negative disease based on the approval for triple-negative breast cancer of sacituzumab, the less of that toxicity we see relatively. So at ESMO 2022, we updated the overall survival. There was a statistical hierarchical design, which is very popular now. So you have to have significance in each prior endpoint to evaluate the next one. So primary endpoint PFS showed statistical significance. At the first analysis, we could look at OS, overall survival, but we didn't have enough events. It wasn't mature. We saw a numeric improvement, but not significant. Now, at this second interim overall survival and the last formal overall survival analysis, we saw a statistically significant improvement in overall survival with a hazard ratio of 0.79, highly significant, and a median improvement to 3.2 months, going from 11.2 to 14.4 months. But also at 1 year, a substantially greater number of patients were alive who received sacituzumab compared to those who received treatment of physician choice. So that was really encouraging, and it allowed us to look at statistical significance, again using this hierarchical design, for overall response, duration of response, clinical benefit rate, all of which were improved with sacituzumab, and also health-related quality of life. We saw in that setting as well that there was a delay in deterioration of global health status, quality of life, and a delay in deterioration in terms of fatigue. So this was all very encouraging data, and I think solidifies the importance of sacituzumab govitecan in heavily pretreated patients with hormone receptor positive metastatic breast cancer.